Hello everyone. Assalamu alaikum wa rahmatullah. Today, inshallah, we will discuss very important topic, intrahepatic cholestasis, obstetric intrahepatic cholestasis. It's a very important topic and it's a very hot topic these days for two reasons actually. The first reason is it's a recent recall. It came 3 times in the exam in February, May, and in November 2023. And the second reason that this guideline has a recent update. So for two reasons, it's very important to cover well before going to the exam. Usually it's a structured discussion question. So you will meet the examiner. Sometimes the examiner will ask you questions about this topic or just one question or one sentence, how you're gonna manage this case. So if it's only one question, how you're gonna manage this case, I'm putting here some questions to help you how to formulate your answer in the exam. So in any structured discussion, guys, my advice or any teaching module for the two stations, please start with the definition. If you don't have a definition for any topic, just to give like introduction about this topic. So usually start with the definition. For the intrahepatic cholestasis, you have to start with the definition and then cover the differential diagnosis, which is very, very important in the exam, to cover it in a very organized way as well. Then cover the management plan and management of labor and postpartum, and touch the point of long-term sequelae. My advice here for the management plan, and you can apply this in all the cases when the examiner asking you about the management, please start with the information gathering, because you will not be able to offer this patient any treatment without knowing more about this patient, just to know about her current history of the present illness, what about her past history, medical, obstetric, menstrual, and so on. And we will come to this point. Here we are in the antenatal care module or maternal medicine module. So when you will come to the point of the management, please, after information gathering, examination, investigations, when you will offer the patient treatment, touch the point of antenatal management, intrapartum management, and postpartum management. So now you are very well organized, and please follow this. It's like general template for any case in the antenatal care or maternal medicine cases. In any structured discussion, usually you will be assessed in 4 domains: information gathering, patient safety, applied clinical knowledge, and communication with the colleague. So here, there is no patient, so no communication with the patient. We will start with definition. So what about the definition of this obstetric cholestasis or intrahepatic cholestasis? It's a multifactorial condition of the pregnancy. It's characterized by pruritus or itching in the absence of skin rash. Very important point. No skin rash here. With abnormal liver function test, especially the bile acids will be more than 19. So this is the definition. We will not find any cause for that. We have to exclude all other causes. And usually this condition will resolve after birth. The itching and the deranged liver function will come back to normal. How to diagnose? It's diagnosis of exclusion. Yes, you have to exclude other causes just to know there is no liver condition, no viral infection or anything. But you can diagnose it with unexplained pruritus or itching, with normal appearance of the skin, raised bile acids more than 19, and this itching, it's special like appearance or special places for that in the palms of the hands and in soles of the feet. So it's like particularly it will suggest the intrahepatic cholestasis. This is the key recommendations from the guideline. I prefer to put it like a screenshot like that to know what about the recommendations from the guideline. When you will start to think about the intrahepatic cholestasis and to diagnose it, you have to consider this in any pregnant lady with itching and normal appearance of the skin and raised bile acid. So it's the same like previous slide, but it's here from the guideline. We need to offer this patient any laboratory or imaging investigations? No, except, so it's not recommended except if we have any atypical symptoms or atypical presentation, if we have any relevant comorbidities, and if it's early onset and it's a severe intrahepatic cholestasis. So early onset in the pregnancy and severe. At that time, we might need to offer this patient additional laboratory or imaging investigations. We need to discuss the care of this patient with a hepatologist if we have a severe form or atypical form or very early onset intrahepatic cholestasis. So at that time, please involve the hepatologist in the management. We can confirm the diagnosis of intrahepatic cholestasis during the pregnancy with these features or criteria, but after the delivery, if you will find the patient start to be normal, no itching, and the bile acids, it comes back to normal. At that time, yes, it was intrahepatic cholestasis. And take care here, guys. This is the first change, or in the recent update. In the old guidelines, it was 10 days. I prefer to tell you the old guideline and the recent. So you will make that change in your mind. So nowadays, we will repeat this bile acids or the liver function 4 weeks after birth. It's not like before 10 days only. Some important numbers, and to be honest with you guys, it's important for part 2 more than part 3. But it's good to have like an idea about this, and also to have the answer for any unexpected question. For the itching in the pregnancy, it's not even common, it's very common, affecting around 23% of the pregnancies. For the intrahepatic cholestasis, the obstetric one, it's 0.7% in multi-ethnic populations. In some ethnic groups like Indian Asian or Pakistani Asian groups, it will be 1.2 to 1.5%. And in Chile, it will be 2.4%. If you don't like the numbers, please just remember this one and that one. Okay? Differential diagnosis, very important. And it's very important slide here, guys. And I put it in a very organized way for you, so you will show yourself in front of the examiners. So you can tell the examiner for the differential diagnosis, we have skin disorders or skin-related, viral infection, pregnancy-related, and liver causes or liver disease related. For the skin disorders, might be atopic eruption of the pregnancy, polymorphic eruption of the pregnancy, pemphigoid gystosis, and allergy. And if you remember from part 2, we have a very famous table regarding these 4 disorders, skin disorders, including the intrahepatic cholestasis. Intrahepatic cholestasis, no skin lesions. And here we have skin lesions. So why are we gonna put it here in the differential diagnosis? Because sometimes the lesions will start a little bit later, or sometimes we'll have atypical presentation of any condition. So keep it in mind, keep it in the differential diagnosis. And I will show you the table in just 1 minute. It's not important here in part 3 to know anything about the other disorders, just to know the names of the disorders. So skin disorders, and then tell the examiner 1, 2, 3, 4. Viral causes like Epstein-Barr virus or cytomegalovirus, pregnancy-related like preeclampsia or acute fatty liver, liver causes like hepatitis A, B, C, cholecystitis, liver carcinoma, liver hemangioma. For the liver hemangioma, usually, guys, it's we will discover it accidentally in good number of population. During the pregnancy, some of the women will have the hemangioma, and it's asymptomatic. With the pregnancy and the stress of the pregnancy on the body, it will start to be symptomatic in the form of deranged liver function. Okay, so that's why we will keep it in the differential diagnosis. So let's recap it again. Skin disorders, atopic eruption of the pregnancy, polymorphic eruption of the pregnancy, pemphigoid gystosis, and allergy. Viral causes like Epstein-Barr virus, cytomegalovirus, pregnancy-related preeclampsia, acute fatty liver, liver causes hepatitis A, B, C, cholecystitis, liver carcinoma, liver hemangioma. This is the table from the TOG article. And it was very important in part two to know what about the areas affected, what about the management and the pregnancy outcome. But here, please just memorize the names, just the names, and that's it. I put it here for you just to remind you with the differential diagnosis we discussed before in part two. Coming to the management, and it's my advice for all the patients in any structured discussion, guys, please go systematic. Information gathering, examination, investigation, and then the treatment or the management plan. And because we are in the antenatal, so make it antenatal management, intrapartum, and postpartum. So you will be well organized in the exam. How are you gonna tell the examiner about the information gathering? So just tell the examiner, I want to ask this patient some questions to know more about her. Regarding the pregnancy, I will ask her how the pregnancy going so far. If she has any problem or had any problem during the pregnancy, any bleeding, any sickness. What about the folic acid in the early trimester, in the first trimester? And for the itching itself, I want to analyze or ask more questions about the itching. Since when it started, any medications received, what increased, what decreased. So ask the question and justify why you're gonna ask about it. For the personal, what you will ask the patient about. Here, guys, by the way, you are following the antenatal care template. So it's the template, and in some questions, I'm gonna say it's important, it's not important, you can remove. In the structured discussion, use the same template and justify your answer, why you will ask this question. For the personal, what about the smoking, alcohol, recreational drugs, and BMI? Why you will ask this question? Because the smoking will affect and will increase the intrahepatic cholestasis. It will make the outcome worse. And also for the alcohol, because the alcohol is affecting the liver. You know that the alcohol, it can lead to liver failure. So we want to know this patient, she might be like alcoholic before the pregnancy, and alcohol already affected her liver. So we want to know more about that. For the menstrual, here it's not important because our patient, she's 35 weeks. If it's early in the pregnancy, yes, we can ask this question. Obstetric, very important. Why here very important? Because if this patient was pregnant before, I want to know if she has the same condition before in any previous pregnancy, and also what about the outcome of this pregnancy. For the patient, for the safety points, or the patient safety points here on the right corner of the slide, what about the blood group of the patient? If this patient can accept blood transfusion or not? If the patient has any drug allergy, and what about cervical screening? It's plus or minus in the antenatal and maternal medicine. If you have time, yes, you can add this question. It's by the end, it's a patient safety point. Then what about the remaining part of the template? The medical, surgical, family, mental, social. So what about the questions we're gonna ask and why we're gonna ask? For the medical history, I'm gonna ask this patient if she has any medical problem of concern, especially for any liver disease. I will ask her if she's on any regular medications, because some of the medications will affect the liver. So I want to know if this patient has any or had any surgeries done in her tummy or down below before. I will ask her about any family history of concern, especially for same condition. Why? Because by the end of this presentation, we're gonna say there is risk of the same condition in the family. So if the patient has intrahepatic cholestasis, for example, her sister will be at risk. Okay, so there is a family risk for this condition. So I'm gonna ask if she has any family history of concern, especially for the same condition. For the mental history, it's very important, any patient pregnant. So in the antenatal, maternal medicine, and management of the delivery, if the patient not in labor now, and also postpartum, it's very important to ask about her mental health by two whole questions, guys. In the last 4 weeks, did you feel depressed or low, not interested to do your usual activities if you are speaking with the patient? So here in a structured discussion, how we're gonna apply? You will tell the examiner, I need to check her mental health because this itching will affect her mental health. If you see this patient one time, you will not forget it again, because the patient is affected with the itching. She will not be able to sleep at night. So I want to know What about her mental health? Because she's at risk to have depression, psychosis, and postpartum depression, postpartum blues, and or postpartum psychosis. So it's very important to touch this point. Social, what about support at home? Why we will ask this question? Because this patient will need support. If there is no support at home, so we can arrange a suitable or appropriate support for her. So after finishing the history, then coming to the examination, just touch the point of the examination. You will tell the examiner, I will examine the patient like general examination, or about the color of the skin, the color of the eyes, abdominal examination to check the size of the liver and also to check the pregnancy, and what about the size of the pregnancy. And you will offer her the investigation, especially the bile acids, and that's it. Okay, the bile acids, no extra investigations unless we have any comorbidities or severe form, early onset, or you are not sure about the diagnosis. So the examination investigations, it's just one line here. Then it's very important, guys, in any patient with any medical condition to discuss with her the effects of the disease on the pregnancy and the pregnancy on the disease. And here, the pregnancy on the disease, actually, this condition induced by the pregnancy. So the condition may be worse because the same cause is still there, which is a pregnancy. So what about the effects of the disease on the pregnancy itself? So premature birth, especially iatrogenic, because we will discuss now that the severe form, we will induce the patient or we will offer her delivery earlier. Increase likelihood of the meconium passage. Stillbirth, which is the poor outcome, and we will not be able to predict the stillbirth. Very important. The important points, I put it in red here. So cannot currently be predicted. It will increase in the twin pregnancy. It will increase in any comorbidities like patient with gestational diabetes, patient with preeclampsia. No specific method during the pregnancy antenatally for fetal monitoring to avoid or to predict the stillbirth. Ultrasound, CTG, not reliable methods for prevention of the fetal death. Continuous fetal monitoring in labor, it's offered. So, however, it's not reliable during the pregnancy, but we have during labor to offer this patient continuous fetal monitoring. Very important. So, what about the stillbirth? So, we will not be able to predict. However, in some patients with a risk factor or a comorbidities like diabetes, preeclampsia, multifetal pregnancy, twin pregnancy, it will increase the risk of stillbirth. I will advise the patient that no treatment will reduce the risk of stillbirth or to improve the outcome of the pregnancy. And don't offer ursodeoxycholic acid routinely for the purpose of avoiding or to prevent the stillbirth. Usually we will offer to reduce the itching, okay, but not to improve the pregnancy outcome. Very important table, the classification. Very important to know, because now, depending on the classification, we're going to say how we will offer the patient follow-up and when you will offer the patient delivery. So depending on this classification, we will comment on two things. What about the follow-up and what about the timing of the delivery? So if the bile acids less than 19, and please remember the number 9, very important, it's gestational pruritus. If it's 19 to 39, so it's mild. If it's 40 to 99, it's moderate intrahepatic cholestasis. If it's more than or equal 100, at that time, it's severe intrahepatic cholestasis. So less than 19, it's gestational pruritus. 19 to 39, mild. 40 to 99, moderate. More than or equal 100, it's a severe. How you will offer the patient follow-up, and usually I will ask you here a question, and usually I'm asking my candidate this question. So in the mild and moderate, we will offer the patient bile acids weekly, every 1 week. For the severe, no follow-up. So my question here, guys, does it make any sense? Usually with any severe form of any disease, the follow-up will be more frequent. So does it make any sense? Just I'm asking this question to remind you in the exam. Okay? It doesn't make any sense. Apart from one thing, that we will deliver this patient early. So there is no change in the plan. The patient is severe, we will deliver her early. But for the mild and moderate, the patient might be mild, and next week it will jump to moderate. Next week it will jump to severe. So the plan or the management plan during or the timing of the delivery will be changed at that time. So why mild, moderate, we will follow up, and severe, no follow up because of this point, as no change in the plan of the delivery. I will come to this next slide, but I love to comment on to comment on this here on that slide. So management, don't forget the multidisciplinary team. And here we are in a structured discussion. So tell the examiner, her management has to be with a multidisciplinary team, including my consultant, a specialized nurse, a specialized midwife, hematologist, physician, neonatologist, plus hepatologist if needed. So the hepatologist, we will keep it for the severe, atypical, early onset intrahepatic cholestasis. But we can add here the hepatologist. Once we will diagnose, what about the follow-up? Mild, moderate, weekly until delivery. Severe, no follow-up, as it will not affect the timing of the delivery. So please remember this. It's also a difference here in this guideline. Postnatally, don't forget liver function. We will repeat 4 weeks after the delivery, not 10 days. So this is management plan, antenatal. What you will give to the patient, please, most of you will forget the treatment. So you will comment on the antenatal, and then what about the timing of the delivery? So what you will go to give to this patient, what you will offer for this patient to reduce this itching. So we can offer her 3 and avoid 3 to make it easy. So give 3, avoid 3. What we will give, topical emollients. It's not that much effective, but it will reduce the itching a little bit, like calamine lotion. Ursodeoxycholic acid, yes, we can give. It will improve the itching and liver function a little bit, but it will not improve the stillbirth risk. It will not improve the outcome and safety of the baby or of the fetus. For the systemic treatment, we can give cholestyramine. No, this is the first one we will avoid. Why? Because it will exacerbate the vitamin K deficiency, and it hasn't been subjected to a randomized trials and not in clinical use. So remember here 2 words about cholestyramine. It will exacerbate the vitamin K deficiency, and it's not in the clinical use. Antihistaminics, we're gonna give, yes. So topical emollients, yes. Ursodeoxycholic acid, yes. Antihistamines, yes. It will give a welcome sedation. It will not improve the itching that much, but it will make this patient sedated during, or it will give her some sort of sedation, especially at night. Activated charcoal, no, do not relieve the pruritus, so I will not give. So here 3 I will give: topical emollients, ursodeoxycholic acid, and antihistamines. What I will not give, cholestyramine, activated charcoal, and steroids. In the next slide, I will not give. Dexamethasone, systemic steroid, should not be the first line, and it's only in the randomized control trial. Okay? So it's only in the randomized control trial, should not be used outside it. So I will not give. So 3 to give, 3 better to avoid or don't give. Timing of the delivery, it will depend on the bilirubin level. So for the timing, if we have a mild, so please deliver this patient by 40 weeks. If you have moderate, deliver the patient 38 to 39 weeks. If we have severe, so 35 to 36 weeks. Why we will deliver this patient here and this patient there and this patient 35 to 36? Because they found that the risk of stillbirth, it's similar to the background in the mild patients till 40 weeks. It's like the background in the moderate patient till 38 to 39. That's why we will induce the patient at that time. And for the severe, advise that the risk of stillbirth is higher than the background. So consider planned birth at 35 to 36 weeks. Okay, so that's why we will follow mild and moderate, and for the severe, you will plan the delivery from the start or from the diagnosis of intrahepatic cholestasis to be around 35 to 36 weeks. Intrapartum. So now we mentioned the timing of the delivery. Antenatal covered. Intrapartum. So follow the template. We are here in the antenatal care. So it has to be under the multidisciplinary team. Please add the baby's doctor or the neonatologist here. It has to be in the consultant-led care unit, normal vaginal delivery or induction of labor, except any obstetric cause, and we will go for cesarean section. This patient has to have one-to-one support and continuous monitoring by the CTG. So this is the intrapartum care from the template. Postpartum care, again, follow the template and then add specific points to the condition. We mentioned that before in any medical condition or during antenatal care. When you will touch the point of postpartum, mention all the points from the template, and then if this patient needs extra support here or extra investigation, extra management, we will add this point. For example, here's a template. We will cover breastfeeding. We will advise this patient regarding the breastfeeding and it's safe. We will advise her regarding the early mobilization. We will assess her regarding the risk of VTE, and if there is any risk, we can offer her low molecular weight heparin and elastic stocking. We will discuss with her the suitable contraception, and we'll come to this point in details next slide. And the neonatologist to check the baby for any problem. So this is the template, correct? What about the extra point, liver function 4 weeks postpartum? Vitamin K we can offer if the patient has prothrombin time, prolonged prothrombin time. Okay, so in the old guideline, it was to offer here and to consider if it's not prolonged. But in the recent guideline, no consider. It's just to offer if the prothrombin time is prolonged. So this is how you will manage the patient postpartum. What about the long-term sequelae? For the follow-up, for sure, 4 weeks. If you can see, I added this point many times through the presentation because it's very important. What about the long-term sequelae? I will reassure the patient that there is no long-term sequelae for the mother or the baby. However, there is a high recurrence rate, 45 to 90%. And there is incidence of or increased incidence or risk of the obstetric cholestasis in family members. So this is the long-term sequelae. Contraception advice, and it's here we have a recent update. It's different from the old one. All methods we can give, except the combined, but when you will not give the combined, if the patient has any previous cholestasis after using combined contraception or any estrogen-containing methods. So take care of this point, guys. In the old guidelines, in the old guideline, it was all methods except combined for the obstetric cholestasis. Nowadays, in the recent update, no, give combined, no problem, except if the patient has a cholestasis before provoked by the combined pills or any estrogen-containing methods. Okay? So this is the long-term sequelae. Please comment on the, reassure the patient, comment on the recurrence. Please give one comment on the family risk here and the contraception advice for this patient. Okay? So this is our last slide. I wish it's clear. It's very important topic. So please just go through this topic carefully for the exam. Thank you so much. Assalamu alaikum wa rahmatullah.